5% of the patients can have optic atrophy. Visual symptoms usually seen in 20%, but if you do a testing like optical coherent tomography or visual evoked response, then we will see abnormality, even mild, in almost 100% of the patient. Oculomotor abnormality include square wave jerk, which is a fixation instability. They can also have saccade abnormality or dysmetric ocular dysmotility. Deafness is seen in 13%, but I have seen one paper which says 1%, so it may range from 1 to 13%. Scoliosis is very common. It's almost 2/3 of the patient have scoliosis, and if you do X-rays, maybe almost 100% may have mild deformities. And same as like a foot deformity, you can see that in almost 2/3 of the patients. Cardiomyopathies in 66% of patients, and initially they have hypertrophic cardiomyopathy and then later become dilated. And they can also have fatal arrhythmias. Patients can develop mural thrombi and they can lead to stroke. So patient can present with stroke and Friedreich's ataxia due to cardiomyopathy. Diabetes, it says 30%, but 20% of the patients have glucose intolerance and 10% have frank diabetes. And it's due to decreased production of insulin because the pancreas is also affected, and also decreased insulin resistance also. Autonomic dysfunction usually cause temperature instability and swelling and color change in lower extremity, and also bladder dysfunction can be seen in 40% of the patient. Cognition is usually not impaired. There's a recent paper in which shows that the patient presented with segmental spinal myoclonus as a presenting symptom of Friedreich's ataxia. So I want to show you a square wave jerk. If I can. Was working before. No, I think it's not working, but it was working before, so I don't know why. That's okay, I can. It wasn't when I did it. Oh, that's why. Okay. Now it will work. Happened and just close it then. Okay. Sorry, didn't work.
I'll try clicking again through the presentation.
So in this diagram, you can see involvement of spinal cord, posterior column, anterior column, and Friedreich's ataxia. And this child, you can see scoliosis, some foot deformity here too. And Babinski sign positive because of this corticospinal tract involvement, absent reflexes because of peripheral neuropathy and also root ganglion involvement. Very few conditions give you both upper motor and lower motor signs. So this is one of them. The other condition is vitamin B12 deficiency. You can see foot deformity, Pesce with hematose here, cardiomyopathy with conduction defect. So just a constellation of symptoms you see in Friedreich's ataxia. As I said, 25% of the patients do not fulfill the diagnostic criteria, so it is called atypical FIRDA, and 15% of them have late onset and very late onset, as I described before. 12% they have retained reflexes, and it's again due to small repeat and compound heterozygous, and they start symptoms late also, and very slowly progressive condition of Friedreich's ataxia. Spastic paraparesis without ataxia, again, is mild condition and late onset. Isolated cardiomyopathy with late onset ataxia. These patients have usually larger repeat, and they present with cardiomyopathy first, and then they can develop ataxia. Chorea and pure sensory ataxia is very rare. So as I said, I'm going to present a few of my cases just to show you the diversity in the clinical presentation. So my first case is a 17-year-old female. She presented with progressive cardiac failure at 6 years of age. She had cardiac transplant at 7 years. 2 months later, then she developed progressive difficulty walking and fine motor activity. She was extensively evaluated and at 10 years of age, and then diagnosed with Friedreich ataxia at 12 years of age. She was wheelchair bound since 14 years of age. She's unable to write or feed but can use computer. She has some mental retardation, which is unusual in Friedreich's ataxia. She also has slurred speech, dysarthria, and swallowing problem. And her exam showed typical findings like bilateral nystagmus, contractures, and anti-gravity muscles, positive Babinski sign, severe dysmetria. And her repeat shows 1,300 to 1,600. So you can see that these are larger repeat. The common repeats are 600 to 1,200. So that may be the reason that she presented with cardiomyopathy before presenting with ataxia. The second case is an 8-year-old male who started with gait and balance problem at 18 months of age, which is very early. Then developed progressive speech problem at 5 years. He started falling more frequently, at gait difficulty at 6 years of age. He was diagnosed with scoliosis at 6 years, and then with Friedreich's ataxia at 8 years. So you can see that it's a slowly progressive disease, and all the symptoms might not be evident at the at the start. So that's why it takes a little longer to diagnose Friedreich's ataxia. He had worsening of scoliosis and gait difficulty. His echo showed thickening of ventricular wall, which is early presentation, like hypertrophic cardiomyopathy. He was doing excellent in school, except that he was having some difficulty writing. And his exam showed typical finding of upper motor and lower motor neuron lesions. And his genetic test shows 900 to 1,000 repeat, which was common repeat. My third case is a 12-year-old female. She started with muscle cramps for several years, and then had the genetic testing because of the family history, and she was positive. And then she developed progressive weakness and gait difficulty, then mild scoliosis, echo showed obstructive cardiomyopathy, and she was able to ambulate but use wheelchair in school. Our exam typical findings, and her repeat was 825 to 1290. So if you compare the patient 2 and 3, the age of onset was much different. As we say that it depends on the GA repeat. Is not the only reason to have diversity. So 50% of the reason to show diversity is because of GA repeat, but 50% is due to other reasons like environmental factor, number of non-GA repeat interrupting the GA repeat, or mitochondrial DNA sequence, and also the expansion of GA repeat in somatic cells, because these repeat continue to expand in somatic cells and cause progression of disease. So these are all the factors which actually give you diversity. It's not just the number of repeat. How to diagnose Friedreich ataxia? Clinically, you can suspect, but the definitive diagnosis is by genetic testing. As I said, it's a trinucleotide expansion disease, so we send for target mutation analysis to look for the GA repeat expansion. Mm-hmm. And if you have one GA repeat in one allele, then you can send for the sequence analysis to look for the other type of mutation, like point mutation or deletion. So if the patient don't have GA repeat, then it means they don't have Friedreich's ataxia. To date, there is no case has been described or diagnosed with Friedreich's ataxia which who don't have at least one allele with GA repeat. MRI brain we usually do, but it's normal initially, but it can show atrophy of upper cervical spine and also cerebellar, especially dentate nucleus. Nerve conduction is steady, will show decreased sensory nerve action potential due to sensory neuropathy, axonal neuropathy. Sensory evoked potential, brainstem auditory evoked potential, and visual evoked potential also show decreased amplitude. MRI tractography is to detect a specific tract degeneration, like corticospinal or spinocerebellar tract. Phosphor MR spectroscopy is to look for mitochondrial dysfunction, and it revealed decreased ATP production. PET scan also can be done. But last three, we also do frataxin level for research purpose, not routinely. So these tests, last three tests, usually be done by specialized centers only for research reasons. So progression of frataxin is variable. It's a slowly progressive disorder, and progression is rapid if you have larger repeat, and if the age of onset is before 15 years. Average time from onset till wheelchair bound is 10 years, but usually kids can be wheelchair bound by 11 to 25 years. Average age from symptom onset to death is 36 years, but it has been much better because of the multidisciplinary approach and prevention of complications like pulmonary and cardiomyopathy. So death usually due to cardiomyopathy and also pneumonia. These patients are managed in multidisciplinary clinic like a muscular dystrophy clinics, and they usually see cardiology, pulmonary neurology, PM&R also. They usually get EKG and echo annually, fasting blood sugar annually. We do assess hearing every 2 to 3 years, and also swallowing is studied because they can have a lot of swallowing issues and can lead to pneumonias. Sleep is studied to rule out obstructive sleep apnea and also hypoventilation. If they are not following an MDA clinic, then they should be referred by the neurologist to